Good day, everyone, and welcome to today's TK VetKit webinar. My name is Sylvia, and I'm delighted to be your host for today's session. For those who may be new to our TK VetKit, we are a dedicated designer and manufacturers of veterinary endoscopes. Our mission is to make professional endoscopy technology more accessible to the veterinarians and to support better care for animal patients. As a part of this commitment, TK VetKit has launched a webinar series as a platform for knowledge sharing. Through these sessions, we invite specialists from all over the world to share both their clinical insights and practical experience, helping veterinarians integrate endoscopy into their daily practice with greater confidence and efficiency. Today, we are honored to have Dr. Richard Burchell as our speaker. Dr. Richard Burchell is a distinguished specialist in small animal medicine with over a decade of experience in academic and clinical practice. He worked as a lecturer in the University of Pretoria from 2012. We are honored to have him today with us to share his knowledge and experience. After this presentation, we will have a short interactive Q&A session. If you have any questions, please feel free to type them into the chat box or use the raise hand function. Now, Dr. Richard, please begin your presentation. Thank you.
Thank you very much. I will just get it up, and if you can just then give me a thumbs up that it's all up on your side. You can see it okay?
Yes, I can see your screen.
Okay, fantastic. Hello, everyone, wherever in the world you might be joining me from. And I hope that this webinar will be informative for you. It's always a mammoth undertaking to try and, I guess, condense a large amount of material into what is a relatively short time frame. And so when I thought about this, I thought, well, what I'd like to try and do is at least, I can't possibly cover all the different applications, different disease processes that we have and that we have available to us. But hopefully what I can do is inspire you to make a start if you haven't already. And if you have already, maybe encourage you to expand your repertoire of skills. Rigid endoscopy is the oldest form of endoscopy, and it predates flexible endoscopy, which we also can use and which I will illustrate examples of. We can use in rhinoscopy and cystoscopy, depending on what your preference is. But rigid endoscopy is actually the oldest form of endoscopy, and it's technically the easiest to do because one of the challenges with flexible endoscopy is the orientation of the endoscope, where it can be rolled over or it can be turned to the side, and you're not always sure exactly anatomically which way is which. Whereas with rigid endoscopy, because you are holding a rigid endoscope, you know which way is up and down and left and right. It's often easier to navigate when you're starting out. So it might be a good place to make a start if you haven't yet started doing endoscopy. The other thing is that if you are offering these services in your clinic, you really are differentiating yourself, particularly with cystoscopy, because if you're able to evaluate the urinary tract without doing surgery, that represents a significant diagnostic advantage that you have over the more invasive traditional diagnostic modalities. So what we're going to do is we're going to look at rhinoscopy and cystoscopy. We're going to look at some of the indications. We're going to look at what we use endoscopy for. We're going to consider some of the equipment that you might need. There are obviously a lot of different potential options for you on the market. And that's also where companies like TK Vet can help you, because you can say to them, I'm looking for a rigid scope that's this length and this diameter with this kind of working channel, and then they can look in their catalog and find something that's fit for purpose for you. And then we're going to have a look at very briefly at the preparation. We're going to look at the procedure, and then we'll also look at a couple of, we'll discuss some potential complications as well. So if we start with rhinoscopy, the typical indication, or one of the reasons why we would want to do rhinoscopy, would be a nasal discharge. We might also consider rhinoscopy in a case of sneezing or reverse sneezing, or if we have stertor or bleeding from the nose or epistaxis. A couple of things to think about, because you often are not just going to jump straight into an endoscopic procedure. And that's going to depend on things like if it's acute. For example, acute sneezing in a cat, more often than not, will be snuffles or feline herpes or calicivirus, and it'll be something that'll go away on its own. So you wouldn't want to be jumping in to doing endoscopy or rhinoscopy in those kind of cases. The other thing to consider is things like dental disease, particularly oronasal fistulas. I've had these before presented for nasal workup. And then also, if you have epistaxis and you're wanting to consider doing rhinoscopy, always remember that systemic disease and bleeding disorders can cause it as well. So we really want to make sure that we have checked this before we go and take biopsies. You wouldn't want to be biopsying a nose on a dog with ehrlichiosis or immune-mediated thrombocytopenia, or a bleeding disorder, and then find you can't stop the bleeding, and then at that point find out that the platelets are low or there's hypocoagulability. And then some other considerations would be things like signalment. So young dogs, we can potentially suspect foreign bodies. Older dogs, we can consider things like cancer. And then also, depending on your geographical location, so where I am in Australia, where I am at the moment, mycotic rhinitis or sinonasal aspergillosis is not as common. We do see cases, but when I practiced north and further up in Townsville, then I found that mycotic rhinitis was much more prevalent. So if we have a look at a couple of things just regarding the clinical signs that we rely on, there was a study that looked at the nature of nasal discharge to see how helpful it was to narrow down your possibilities. And so if we have a look at the top, we've got non-specific rhinitis, NNP was cancer, FB was foreign body, MIC was mycotic rhinitis or fungal, and then miscellaneous was a whole lot of other diseases thrown together. And you can see that for both non-specific rhinitis, cancer, and a foreign body, we can see that it can be unilateral or bilateral. And so we can't exclude bilateral disease. We can't exclude a non-specific rhinitis if we have bilateral disease. And we can't exclude a cancer if it's unilateral alone. So these things can help us, but the take-home message is that there's considerable overlap between the signs as the nasal signs as far as the different nasal diseases go. If we look at the nature of the discharge, we can also see that there was an even mix between serous mucus, pussy or purulent, and hemorrhagic or mixed nasal discharges. And so basically there was no real statistically significant difference between the type of nasal discharge and the type of disease that was observed. And then if we look at some of the diagnostic imaging findings, we can see that the only things that were statistically significant was if there was a mass in the nose, if there was an osteolytic lesion. So in other words, bone destruction was more likely to be consistent with cancer. So the only reason I included that is because as a lecturer, over the years, we've taught students, it's very important with a nasal discharge to make sure, is it unilateral, is it bilateral, is it serous, mucus, purulent? And we put a lot of emphasis into that clinical side of things. But in actual fact, it doesn't really help you narrow down the causes as much. The nasal discharge and the nature of the nasal discharge. What's more helpful is other things like the signalment, the chronicity, is there facial deformity, is there nasal depigmentation. I find those findings are much more helpful. If we look specifically at epistaxis or nasal bleeds, this can be particularly confronting to an owner. And so it's always important to remember when we see bleeding that bleeding can also be caused due to clotting disturbances. And so we always need to consider bleeding can be due to blood vessel damage because there is a cancerous process or an inflammatory process, fungal invasion of the tissue, or immune-mediated diseases, but it can also be due to coagulopathies, particularly thrombocytopenia, rat bait toxicities, or your vitamin K antagonists and other bleeding diatheses. So it's very important prior to doing a rhinoscopy that you have excluded those bleeding disorders. Another way of looking at it is that you can have focal or systemic diseases. So your focal diseases would be cancer of the nasal passage or a foreign body or infection, and systemic causes would be things like bleeding disorders, hypertension, or hyperviscosity syndrome. And so if we have a look at what some of the common causes of epistaxis are in dogs in one fairly large study, we can see that it was more common to see unilateral epistaxis in dogs that had local disease. But importantly, 52% of dogs with systemic disease also had unilateral epistaxis. So once again, even though you might have had it drummed into you as a student, and if you were one of my students, I might have drummed it into you, differentiating between unilateral versus bilateral, these are guides, but unfortunately they are not reliable differentiators of local versus systemic disease. Okay, so that's some of the background to what we might want rhinoscopy for. What are some of the things that we need to consider prior to doing, or what is some of the preparation we need to do prior to doing rhinoscopy? Well, I don't know, depending on where in the world you might be listening to this from, but increasingly, we come under pressure from a cost perspective to ensure that everything that we do is financially justified. And even in dogs with insurance, we find this because, insurance can run out. So we've got to be able to do a rational set of defensible tests that are justifiable in order to give us the most appropriate diagnosis. And so in a case that you plan to undertake rhinoscopy, a complete blood count, CBC biochem, and coagulation testing would be a standard consideration and would be at least what would be considered a minimum database for a rhinoscopy. Blood pressure is not a bad idea because you can sometimes see epistaxis, and certainly hypertension could worsen bleeding if you're going to take biopsies. An ophthalmological examination can be helpful too. I must confess that because I worked in multidisciplinary environments for long enough, my personal ophthalmology skills are wanting, and so I don't do this personally myself, but an ophthalmological examination can help, particularly in cases like with epistaxis, where you might see hyphema or retinal lesions that are consistent with systemic disease or with coagulopathies, and that might steer you in a different directions. Things like lymphoma, FIP in cats, leptospirosis, thrombocytopenia due to ehrlichiosis. So there might be some clues for you there. And then imaging. Well, ideally, if you had the option and costs weren't a limiting factor, you would probably do a CT pretty much before every rhinoscopy if you had the option. And the reason for that is that if you do it afterwards and you cause bleeding and blood clots in the nose, you might need to wait a while before you can do a CT that you don't have bleeding or fluid in the nasal passages obscuring lesions. And so ideally you do a CT prior to. Now, I will often do rhinoscopy without doing a CT, but I'm always going to have that conversation with the owner about the fact that rhinoscopy has its limitations. So particularly if you have tumors that are submucosal or they're deep within the nasal tissue, they may not be readily identifiable on a cystoscopy, and there might be exudate inside the nose that limits visibility, and so you might miss a lesion. I always have that conversation with owners prior to that. So some of the major limitations are that the nasal discharge can obscure the view, which means that if you can think about it, if you are swimming in your swimming pool and you're looking for a piece of jewelry on the bottom of the swimming pool, if the water's dirty, it'll be harder to find than if it's clean. So if you've got a nasal discharge, that can cause a lack of visibility, and it can be difficult in order to identify lesions. And then obviously, if you have a mass that's inside the nose, it can obliterate the lumen, and it can be a case of, well, you just can't get the scope in a position that you can visualize the mass because the mass is taking up the whole nose. Okay, so if we look at preparation, I carry 2 rigid scopes, and you don't have to have exactly the same scope. Some clinicians will have different scopes, but I use for dogs that are bigger than 5 kgs, so 5 kgs and up, I will use a 2.7 millimeter scope that has about 14 centimeters of working length. You can use a 0 to 30 degree bevel. Now, what that refers to, that's the angle of the lens, and the wider the angle is, the more you're able to see, I guess, perpendicular to the scope. So 70 degree scope, you can see almost perpendicular to the scope. You have a more of a sort of, I guess, a panoramic view. That might not be the best way to put it, but you're not seeing directly in front of you. Whereas with a 0 degree bevel, you can only see directly in front of you. Personally, I find that that the scope that's the most of an all-rounder for me is the 30 degree bevel on the lens. And the reason for that is that if you have a 0 degree scope and then you're wanting to do cystoscopy, sometimes you can battle to see ureters because you can only see directly in front of you. So this is just my personal preference. Bearing in mind, you're going to have to put a sheath on that scope. So when you put a sheath on that scope so that you can have flushing and a working channel, it's going to potentially push it out to about 3.5 to 4 millimeter diameter, depending on your sheath. And then for cats and very small dogs or short-nosed dogs, I will use a 1.9 millimeter scope, and that has about a 10 centimeter working length. So if you buy one scope, buy the 2.7, unless you are a majority cat practice, in which case buy the 1.9. But you're not going to be able to get a 2.7 millimeter scope into the vast majority of cat noses. You can also use a flexible scope. So particularly for the retroflex view, that's when we will retroflex, or we will curve the scope open 180. We'll hook it over the soft palate and pull it into the back of the nose and look at the nasopharynx. You can use a gastroscope for that. Sometimes you can use a bronchoscope. And if you have a very, very narrow, like a 3 or 4 millimeter flexible scope, you can also use that for rhinoscopy. And some clinicians prefer that. It's not my personal preference, because with flexible scopes, you don't quite have the same resolution, even if you've really got a good scope, because it's digital, whereas a rigid scope is a glass lens, so you get a crystal clear image. And also sometimes if you're trying to find your landmarks using a flexible scope, you're not 100% certain what your orientation is. Whereas with a rigid scope, you always know exactly which way is up, down, left, right. So I tend to favor a rigid endoscope for rhinoscopy. It's my personal preference. Couple of things. Now, if you buy a scope from TK Vet or from one of the scope suppliers, they will often supply you with biopsy forceps that you can feed down your working channel on your sheath. They're not a bad idea to have those, but you don't get decent biopsies with them. So I don't know what they're called. I think they're called ENT forceps. I have suppliers who know what I'm talking about. But these are about these forceps that I'm showing you. They have a large cup, and they're about have about a 10 centimeter working length. And these I'll feed blind into the nose, or using, if you've identified a lesion, you'll mark it off on the scope and you'll collect tissue in that region, and you'll collect large chunks of tissue. I strongly recommend that you use forceps like these for biopsies, because you often get such tiny samples from the biopsy forceps that feed down the sheath that the pathologist just sits on the fence. So have some decent ones. Not a bad idea to have some graspers that go down your scope. You might see a foreign body that you want to pull out. And then also, your scope will need a sheath. And I would recommend that if you have one sheath, because I have two sheaths. I have a 2-port sheath and a 3-port sheath. So I would recommend that you have a 3-port sheath, because you've got one sheath for flush, you've got another one that you can suction from, and you have a third one as a working channel. So that's what I would recommend. And then just make sure that you've got a kit for bleeding if you have a bad nasal bleed. Always prepare for a nasal bleed. Okay, so for the procedure, I like to put them in sternal recumbency, and I quite like to use a rabbit gag as shown in this image. The reason for that is that I'm able to examine the throat. I can put my flexible scope down into the nasopharynx and have a look at the nasopharynx from the back. And then I can secure the airway. I can pack some gauze swabs into it, and it just gives me good control over the patient. But you certainly don't have to have this. And I have, in many occasions, done rhinoscopy without a rabbit gag, just by propping their head up on a stack of towels or Inco pads or what have you. So you don't have to do it. But if you have a rabbit gag, particularly if you are doing a lot of Boaz surgery, and that's what you use it for, this is a very helpful positioning aid. Okay, so if we have a look at the retroflex view, and I'll show you a side view in an instant. But basically what we do is we take a flexible scope, we flex it over 180 degrees so that it's like a hook, that we're looking back at ourselves. And then we slide it into the mouth over the soft palate, and we hook it over the soft palate and pull it back towards us. So that's what that's what my colleague is doing in this image here. She's got the scope retroflexed, and then she's hooking it over the nasopharynx, and she's looking into over the soft palate, looking into the back of the nasopharynx. So basically what this looks like on the side view is, you can see you've inserted the scope and it's flexed over 180 degrees. You've slid it down to the back of the throat and then pulled it forward and hooked it on the soft palate. And then you're able to pull it towards you in order to visualize the soft palate. So this is what this will look like. So we're starting off, the scope is being inserted. We've hooked it over the soft palate. Now we've identified the opening. We're positioning ourselves, and then there's an annoying bubble in the way. So we're just moving around, trying to position ourselves. And if the bubble doesn't clear, what you can do, and I did it in this video, but unfortunately I didn't capture that image for you, is you can just put some flush down the nose, and that will break the bubble for you. So this is looking into the nasopharynx. There is a bubble in the way, but we can easily fix that. So that's the retroflex view. That's probably the easiest scope, technically the easiest one to do, because it's literally just hooking a scope over the soft palate and pulling it towards you up into the nose. Okay, so it's technically the easiest, but if you can access the nasopharynx from the anterograde side, in other words, we'll get onto the anterograde rhinoscopy now, and that's where you put a scope into the nostril and then go into the back of the nose. You should, in most cases, be able to pass the scope through into the nasopharynx. from the nostril into the nasopharynx. And if you've done that bilaterally on both sides, you've probably adequately visualized the nasopharynx. And in that case, I won't get two scopes dirty. What I would suggest if you're starting out, though, as much as it might irritate your nurses or you if you have to clean your scope, I would recommend that you start doing both, because it takes a little bit of time to get confidence that with anterograde rhinoscopy, so from the nostril into the nose, that you've got all the way through and visualized all the structures. And that'll become a little bit apparent when I show you a couple more videos just in a few slides' time. Okay, so what the retroflex view is helpful for is it for foreign bodies, especially in cats. So cats like to get foreign bodies in the nasopharynx. This is a good way to visualize them. Also for polyps, cats can get polyps in that region, and very much for aberrant turbinates. I'll show you an example of those in a case in later on in the slideshow. But aberrant turbinates can be a very big reason or can be a major contributing cause to the lack of success of a BOAS procedure. So when BOAS procedures, a staphylectomy and narroplasty are unsuccessful, that'll often be because you have aberrant turbinates that are occluding the choana, which is the back of the nose. I'll show you that in a bit. And then obviously you can see some cancers, and you can also see nasopharyngeal stenosis. So this is an example of a grass blade in the nasopharynx of a cat. And in cats, what we'll see is gagging, retching, difficulty swallowing. We can also sometimes see polyps in this region. They arise from the eustachian tube and they project into the nasopharynx. These are very satisfying to treat, I find, because you grasp them on the base and you pluck them off. It's called traction avulsion. It's a very successful procedure. Okay, so aberrant turbinates are edematous mist-formed turbinates that will project into the back of the nose. On the CT image, I don't know if you can see my pointer on the CT image, but on the CT image, just above the cross-section of the ET tube, you'll see two sort of misshapen black holes that correspond to the choana, and that's lined by turbinates and mucosa, and that should be open. And if you have a look at the bottom right of your image, you'll see within the nasopharynx, you've got that mucus-covered, dense, edematous tissue that has completely occluded the nasopharynx. And the only breathing hole that that dog has got to breathe through is a tiny little hole over here. Is there a drawing function on my... I don't know if you can see my pointer, but there's a tiny, tiny little hole where the opening to the nose should be. So all of that area of the choana is completely occluded with abnormal tissue. This is an example of an adenocarcinoma in the nasopharynx, and we can see squamous cell carcinomas and sarcomas there. And then this is an example of a fungal plaque that's been visualized from the nasopharynx that's projecting into the back of the nose. We'll talk about this a little later. Okay, so if we have a look at anterograde rhinoscopy, this is where you're using a rigid scope. So we're using a rigid stainless steel scope, and we are pushing it through the nose and the nostril into the nose, trying to get it as far back as we can into the nose. Bleeding is an issue with this. The scope is rigid. The nasal mucosa is extremely delicate and friable, and particularly if they have rhinitis or inflammation, it becomes extremely friable and it's prone to tear and bleed. And so you really need saline with a pressure bag. So I have a saline line connected to the flushing port of my scope, and we run constant flush with that. And you've got to make sure that your nasopharynx and your airway is protected while you're doing this. Okay, so if we look at the positioning, once again, it's typically the same. And if you look at the bottom left of the image, the Doberman, you'll see that the scope is being inserted to the nose, and you'll see there's a little drip line running into that. And that's the flush. And that flush is very important to keep your lens clean. So think of it like you're driving your car on a muddy road and you've got stuff splashing up on your windscreen the whole time, if you don't have your windscreen wipers going, you're not going to be able to see what you can do, what you're doing. Positioning, once again, sternal. As I said, a rabbit gag works well, or any other gag is also acceptable. Intuition is absolutely crucial, and cuffed ET tube is very important. Okay, so this is a video that I've taken from Ettinger's textbook of veterinary internal medicine. This Dr. Gerard Uchtering does really great videos, and this is one of the best videos. I couldn't make something like this myself, and so I've got this as an example to show you an example of anterograde or rostral endoscopy. So basically, he shows you on the CT a little red dot simulating what you're going to do, the pathway that your scope is going to take. So we're passing the scope down, we're having a look at all of our structures, and then we're moving down, right down into the nasopharynx, and then we've pretty much taken the scope as far as we can. Okay, so in this particular case, the right nasal passage is being accessed. That's the vestibular bulb. You have the little nasolacrimal opening, nasolacrimal duct opening. Bearing in mind, this is a normal dog with a really big nose. Okay. So now we are looking at the nasal septum on the right of the image. And we can see the straight fold and the winged fold. We're looking up into the dorsal nasal meatus. This is the top chamber of the nose. And normally we can't get our scope very deep in there. So we're just looking at the entrance. Okay, we're now moving down into the middle nasal meatus, and we can see the branching of our nasal conchae. Now, as we come back further, we're going to gently push past the nasal conchae. So we direct the scope down ventrally. And then we're going to push gently through the nasal conchae, and they will move out of the way. Now, if you've got nasal pathology, they're often very friable and they just bleed. So we're now pushing down into the back of the nose. So we can start to see the opening to the nasopharynx at the back. That's the opening to the sphenoid sinus with the vomer bone. And that's our view into the nasopharynx. And then on our right, we see the edge of the nasal septum. So now we can look up into the sphenoid sinus and we'll see part of the ethmoid. And then we're moving down into the nasopharynx. So we're now in the nasopharynx. This is a huge nose this dog has, so it's a great example. And then if we're really successful, we'll get all the way down and we'll actually even see the ET tube. Okay, so if you have managed to pass the scope that far, you've pretty much seen everything. And if you do that on both sides, that's a pretty comprehensive study. Now I'm going to show you a real example. This is a dog with nasal pathology. What I'll normally do for the video is I will write down an L and an R on a piece of paper, and then I will just record that in the video before I go into each nostril. Okay, so we're going in. That's our dorsal nasal meatus. You can see there's exudate there. We're now pushing through into the nasal concave, and we're trying to find a pathway through. And you can see how friable this tissue is. There's some exudate on the left there. And so you can see we're now through to the nasopharynx, but it's nothing like as advertised, because we've picked up some nasal tissue, and we've got some exudate, we've got some bleeding, we've got a bubble, but we're in the opening to the nasopharynx, and now we've got some bleeding. I'll just skip forward a little bit. So it just illustrates that although you've sort of got almost all the way through, when there's a nasal pathology, it's just much more tricky than if you have a dog with a really large nose. So this is a 15 kg dog, so smaller with a narrower nasal passage than the dog that was illustrated. I'm going to come back to rhinoscopy again, but I just thought we'd take a break from that and just look at some of the some cystoscopy, and then we'll get back to some specific nasal pathology a little bit later on in the presentation. Okay, so if we look at cystoscopy now, some of the indications would be ectopic ureters. Suspected endoscopy is the best modality for that. Bladder lesions, or if you have a recurrent cystitis that's unexplained, if you're wanting to get a biopsy, if you're wanting to pursue lithotripsy, or if you're trying to find a source of hematuria, where hematuria might be coming from. Fortunately, there's overlap here, because for female dogs, that 2.7 millimeter scope in most cases will be fit for purpose. I used a 2.7 millimeter scope with a sheath quite recently on a 16-week golden retriever female, was able to get that in. Male dogs is a bit more of a challenge, because you need about a 3 to 4 millimeter flexible endoscope with a side port for flush, and it needs to be ideally 60 centimeters, 60 to 70 centimeters, so that you can do most male dogs. Female cats you can do with a 1.9 millimeter scope. Males is not currently possible via the urethra. You have to go into the bladder. So I wouldn't be having a crack at males just yet, unless it's something that you're very familiar with. If we look at the male, positioning dorsal or lateral isn't really as important. I prefer lateral because it's just easier to work with them that way. Females, dorsal or ventral. A lot of clinicians like them to be dorsal, so upside down. And the reason for that is that the external anal sphincter is below the vulva. So if you have any fecal soiling, that it tracks away. And also if you are wanting to put a guide wire into ureters, into the particularly if you're wanting to learn urethral stenting, it's much easier to do in dogs that are in dorsal recumbency. So the clinicians like to do it that way because they become familiar with the anatomy being upside down. I've done both. I don't really have a major preference, honestly. You also need saline to flush because you need to keep everything open. So in females, what you do is you introduce the endoscope into the vestibulum, and then you will hold the vulva closed over the scope, and you will inflate the vestibulum and the vagina with saline until you can locate the urethra, and then you just feed the scope into the urethra. So if you do it this way, it's technically very easy to do. So we are inserting the scope into the vulva, and now we are we're basically putting saline in, and then we're gonna find our bearings. So at the moment, there we go. We've got the opening to the vagina over there, and then the dog is on its chest. So the opening to the urethra is I beg your pardon. The dog is on its back. So the opening to the urethra is dorsal. We're feeding into the urethra, feeding into the urethra. Inflating with saline, feeding into the urethra. This is a dog with recurrent cystitis. So you can see that there is reddening of the urethra. It's had recurrent UTIs, so that's not a normal looking urethra. Feeding into the urethra, and then we're in the urinary bladder. I'll just go back a little bit and just show you. So as we come through, we're coming into the bladder. Oh, beg your pardon. Sorry, I clicked the wrong thing. Okay, so we're in the bladder now, and now because the dog is lying on its back, the urethral openings are going to be at the bottom of the scope because the dog is upside down. And so now we are going to try and identify urethral openings. So we're looking for our urethral openings, bearing in mind that they will be on the bottom of the screen because the dog is lying on its back and because the urethral openings will come in from dorsal. So you can see there where we've rubbed the bladder mucosa with the scope. It's quite friable. And so we should see these openings just in the trigone region at about 10 o'clock and 2 o'clock. So as we look, we're searching for urethral openings, knowing where they should be anatomically. Looking at the bladder mucosa, just going to skip ahead a little bit so we can see what the urethral openings look like. And there we have it. So we're just waiting for the saline to clear a bit. Oh, my word, sorry. Just going to go, I apologize for that. I pushed the wrong button. I paused it at the wrong spot for you. That's the urethral opening. Oh, I did it again. My apologies, guys. I need a producer. So that's the urethral opening in the screen there. So we found it on both sides. And then you can see, if you watch for long enough, you'll see urine discharging from that. Okay, so if we have a look at the male, it's a similar principle. We're using saline to inflate the urethra. This is a much more normal looking urethra. We're in the penile urethra at the moment. So we've just inserted the scope into the penis, and now we're feeding. You can see the urine swirling over there. We've got a bit of mucus on the lens, and so we're just moving the scope from backwards and forwards, just trying to dislodge any mucus. Feeding the scope, we're starting to see the urethra dilate as we feed. In the penile urethra, you're going to pick up a lot of this mucus. You've just got to be patient and let it flush. So we're moving further into the bladder now, trying to keep the scope in the urethral lumen to the best of our ability. You can see the urethra dilating and sort of contracting as we're feeding it with saline. Now we're going to continue to feed the scope, follow the urethra. You can see the curve over the pelvis into the pelvic urethra. So we're now moving into the pelvic urethra. This is a border collie, so it's a relatively large male dog. We're in the pelvic urethra. That's the external bladder sphincter, and you can see prostatic ducts over there. Those little holes there are prostatic ducts, not ectopic ureters. So now we're going to push through that external sphincter. In a small dog, the sphincters will be close to each other. You won't really be able to separate them. When a large dog, you'll actually see that they'll be quite separate. So we've pushed through the internal sphincter now, and we are now in the bladder. Now, what I'll normally do is at this point, depending on how cloudy the urine is, I'll often just completely drain the urine and fill the bladder with saline just to make it easier to see. But as you can see here, we've got our little urethral opening. So that's our urethral opening. So we've confirmed that the urethral opening is in the appropriate position. And there we see the other urethral opening. So you can see the one is a little bit, and you see urine discharging through it. So you can see that these are not perfectly adjacent, but they are both within the bladder. So they are cranial to the bladder sphincter. So they are in the normal position. So that's the male. Ectopic ureters is really something where cystoscopy is extremely helpful, and they are readily identified on cystoscopy. So this is an example of a video. This is the 16-week-old golden retriever dog, and with a history of bedwetting and incontinence and just constantly dripping urine. We've just entered into the urethra, and you can see this band of tissue. So the ectopic ureter is on the bottom of the screen, and we can see the urethra and the urethral opening just above that. So this is a classic unilateral ectopic ureter. And this is an intramural one. So basically, this ectopic ureter is tracking through the urethral wall. And so classic ectopic ureter. Now, what you can do, and it's not very expensive, if you don't have a laser, and I don't have a laser, you can cut these. So you can buy little scissors that fit down your endoscope, and you can identify the ectopic ureter. And using endoscopic guidance, you can cut this open to the level of the trigone. Okay. So I'll show you what that looks like. So we're using the scope, and we are identifying our little ectopic ureter, and then we're going to introduce our endoscopic scissors, and then we're just going to cut this tissue back. Got to be careful not to make a hole in the urethra, but it's not difficult to do. And so we're using the scissors. We're now sliding forward, and we're going to cut this abnormal tissue back to the level of the trigone. Okay, so this dog is fully continent. I've done another one. This one I did months ago. I did another one quite recently, also with scissors, and it was a bilateral, also a golden retriever, and that dog's like 95% continent. So it's significantly improved. So this is a useful little technique. This is just another another example. And basically what we've done here is the main issue with this, and the advantage of laser over using scissors, is that you don't have the bleeding. Here we've introduced a guide wire into the ectopic ureter just so that we can track where we are, and then we're using that guide wire. We can then cut the tissue with our scissors, and we cut it back to the trigone, to the level of the uretero-vesicular junction. So this is something that if you have a rigid endoscope, all you need to do is buy the scissors. I think these scissors cost me about $600. I bought them some time back. But there'll be a number of suppliers you can potentially get these little scissors from, and you basically feed these down the scope, and you can correct ectopic ureters, and you don't need anything fancy beyond having a scope. Okay, so I'm going to cover a little case with you that might be of interest, and then I'm going to finish off just with a couple of specific applications for endoscopy in the treatment of rhinoscopy. So we've looked at surgical procedures that you can do cystoscopically, ectopic ureters. So this is Max, and he actually is, I think he's still alive, but at the time was a 2-year-old French bulldog with a presenting complaint of weight loss. He had had 2 previous Boas surgeries done, but he continued to have stertor and sleep apnea. On a CT, we found that he had severe aberrant turbinates that were, and that's what's outlined by the arrow, that were occluding the nose. And so he had a revision staphylectomy, but it hadn't really done much. And we had done endoscopy to exclude a sliding hernia, and we had identified aberrant turbinates. So basically, we're looking into the nasopharynx, and you can see there's really no hole into the back of the nose. It's all occluded by this aberrant turbinate material. The arrows are pointing to the choana. You can see there's 2 tiny holes there, and those should be significantly wider. So he failed to respond to proton pump inhibitors. The owners did not want to do turbinectomies, and that is where you do laser to cut the turbinectomies. And also, we actually didn't have a center to refer them to at the time, because the center that had been doing it had had a few severe complications, and they weren't doing it anymore. And the owners were considering euthanasia. And so what we did with Max was we took a flexible scope to identify the nasopharynx, and we injected 95% ethanol into the aberrant turbinates to try and induce necrosis. This hadn't been done before, and so we didn't really have an idea exactly how much to do. But what we noticed was that when we injected ethanol in, you could immediately see bluish discoloration of the tissue. You could actually see it turned bluish gray. He had an initial deterioration. He was in hospital for 24 hours, but he improved after about 2 days. But then his clinical signs returned after a few weeks. So this time we went in again, and we were a lot more aggressive, and we sort of did a ring block, which meant we went around and injected in a sort of a ring formation, injected ethanol into the tissue. So here's the aberrant turbinates, and essentially what we did was, you can see on the right of the screen, after we injected ethanol into it. So this is before, this is after. The tissue turns this sort of horrible grayish blue color. That's the other side. You can see that it's turned a sort of a bright purple color. And then once again, he was in hospital for 24 hours. And then after recovery, he improved, and his regurgitation had stopped, and he was markedly improved. But he was presented about 2 months later again with stertor and regurgitation. Now what we found was, if you compare this, I'll go back to the previous image. If you remember, he had all of that abnormal tissue sitting in the choana. Now that tissue was all gone, and what we had was a small stricture, a simple band of tissue stricture. This is what it looked like when we went in endoscopically. And so what we did was we put a balloon in, and we did a balloon dilation and broke the stricture. And you can see the stricture's broken. It's broken on both sides. We managed to open it up on both sides. And this is Max post balloon dilation. You can see the stricture is gone, and he now has a passageway for air. And this little dog has done exceptionally well. We did one last scope on him. There had been a bit of a return of the stricture, but nowhere near as bad as it was previously. But importantly, you can actually see darkness in the deeper part of the nasal passage, and there's a pathway for air. And so, look, this is, I'm not suggesting that you go out and do this. This was, I did lose a lot of sleep, particularly in the post-op period. But the reason I share this case is that if you've got a scope and you are creative, you can find non-invasive ways to treat things. So this is a good example of a non-invasive way to try and treat aberrant turbinates, and using endoscopic scissors is a good example. Here it is. Okay, so we're going to just finish off with a couple of specific nasal conditions where endoscopy is helpful. So if we look at nasal foreign bodies identified by rhinoscopy, there was a study identifying mainly grass awns that could be identified via endoscopy, and these could be readily identified and removed. In cats, remember we said it's mostly in the nasopharynx, and they often will have a cough and regurgitation. And I showed this image earlier of a grass blade in the nasopharynx. I've treated a few of these over the years. They're lovely to treat. You pull them out, and the cat just looks like $1 million afterwards, and you look like a hero, and the owner is really happy. Okay, so the other thing that endoscopy is very helpful with is canine sinonasal aspergillosis or mycotic rhinitis. Now, this is a fungal nasal disease, particularly of long-nosed dogs, and it's often unilateral, but very importantly, we often find that they will have a nasal discharge that temporarily responds to antibiotics. And that's because of secondary infections. And so it's quite common for me when I see these cases as referrals that people will say they improved on antibiotics, but then the clinical signs come back. Another important thing is that the fungus is sometimes only in the sinus. So it's usually caused by fungi from the Aspergillus group. And the diagnosis is most heavily reliant on identifying fungal plaques on rhinoscopy and a destructive pattern. The fungal plaques are very distinctive. They are pale, white, tough, almost have like a mushroom type consistency to them. And another way that we can sometimes diagnose it is if we take a biopsy and we can see fungal hyphae invading the tissue. It's important not to just culture nasal discharge, because you can find Aspergillus in the environment because they are ubiquitous. So just finding Aspergillus in a nasal discharge is not sufficient to confirm the diagnosis. You need to actually visualize the plaques, and you need tissue samples of showing the plaques or showing the fungi invading the nasal tissue. So this was just a study that showed that about 17% of cases here, it was only identified in the frontal sinus. So in this study, they looked at 46 dogs that had nasal aspergillosis, and 83% of those dogs, they found nasal plaques in the nasal cavity, like in this image. But when they did trephination, they found about 17% of the cases where they saw the fungus in the frontal sinus alone. The take-home message from this study was that frontal sinus trephination to exclude mycotic rhinitis is probably quite an important consideration. So just a couple of things, I guess, to think about is culture alone, as I said, is not diagnostic. because Aspergillus can be found in healthy noses. You really need to visualize the plaques or get a tissue biopsy that actually shows invasion. So don't culture nasal discharge in dogs. It's a waste of money. So you can culture tissue if indicated, but don't culture nasal discharge. Another thing, a lot of vets will put them onto oral antifungals. They just don't work. They've been shown time and time again not to work. They're toxic drugs. They're expensive. It's a waste of money. You're better off just putting cream up the nose than giving oral antifungals. So that's what we've said. The topical treatment is the gold standard. And now what is recommended is that you remove the plaques. So now what we do is we will use biopsy forceps and flush, and we will basically endoscopically take all of that abnormal tissue out and remove all of that tissue, and then put clotrimazole or the antifungal cream in afterwards. So if you look at how we can deliver the cream, there's two techniques that have been described. The one is to put a hole in the frontal sinus and to instill the cream that way. Or the other way is to use a scope to pass a wire, a guide wire, up into the frontal sinus, and then feed a feeding tube into the frontal sinus, and then deliver the cream that way. I'll show you some images of that later if it's hard to understand from my description of it. So this is sinus trephonation. And this is a straightforward procedure to do. It's interesting. I did one this afternoon. So it's quite interesting how I'm doing this webinar, and I actually did this afternoon. Basically, you go in between the midline of the dog's head and align with the lateral canthus, or the outside of the eye, and you go about 0.5 centimeter to 1 centimeter in from the midline. And there's plenty of resources on YouTube, on the internet, on AI that gives you the landmarks for these. And in actual fact, normally the landmark that you calculate is actually a little bit rostral. So I often will calculate my landmark based on what I described to you, and then go about 0.5 centimeter to 1 centimeter caudal to that. And then what you do is you just use, I don't know the technical term for this because I'm not a surgeon, but it's basically a hand drill for introducing an intramedullary pin or a Sternman pin. And I will put it in so that only about 1.5 centimeters of the pin is sticking out, so that when you push it through the sinus, as it pops through, only so much pin can go in. Today I had the luxury of using an electric drill, which I've never used before, which made the job really easy, but it's very unnecessary. A hand drill works just fine. And then once you've got a hole in the sinus, you can stick your scope in and have a look inside. Are there any plaques? Is the sinus empty? And then once you've had a look and you're done, you can put a feeding tube in and you put your clotrimazole cream directly into the frontal sinus. The frontal sinus doesn't communicate, so you have to do it bilaterally if you suspect bilateral disease. So this is what we've been doing for a long time, but then there was a group that showed another way to do it. If you have got destructive rhinitis, and if you look at image A at the bottom, you can see that the Aspergillus has sort of eaten out the nasal passages, which means that you can actually visualize the opening to the frontal sinus from the nose, which you can't do in a normal dog. You cannot visualize the opening to or get into the frontal sinus of a normal dog unless it's got a destructive disease like mycotic rhinitis that has eaten out the nasal passages and eaten out the opening to the frontal sinus. But if you have that, you can then use the scope, introduce a guide wire into the frontal sinus, which is shown in image B at the top, and then feed a feeding tube over that guide wire, and then pull the guide wire out, leaving the feeding tube in place. And then if you look at B in the bottom image, you are then instilling cream into the frontal sinus until it appears at the nostril. And if you look at C in the bottom image, that's repeat endoscopy some weeks later, through the opening into the frontal sinus, because that doesn't grow back, so that damage remains. The nasal tissue won't grow back. And you can see that there's no fungal plaques in the nasal tissue. So I thank you very much for your attention. I hope that you found that informative, and I hope that it inspired you to, if you haven't started, start doing some cystoscopy or rhinoscopy, and if you're doing it, to continue doing it.
Okay. Thank you, Dr. Richard. Thank you so much.
It is my pleasure. Do we have any? It looks like there's something in the chat.
Okay. Thank you for your excellent presentation. So now we will move on to the Q&A session. Is that okay?
Yes, I'm happy to take any questions. People want to put their microphones, I'm happy. Otherwise, I'm happy to answer them from the chats as well.
Okay, so everybody online, if you have any questions, please type them in the chat box, and Dr. Richard will answer them very shortly. Yes, I see it. I see the doctor said thank you deeply in the chat box. Thank you so much. If you have any questions, you can type them in the chat box, or you can use the functions of the raising hand, and I can see, and I will open the microphone for you.
Thank you, Emmanuel. It's rare to for everything to be. No, I am inclined to agree. I think endoscopy, particularly cystoscopy and rhinoscopy, is one of those type of clinical practices where everything is pretty straightforward and very visual. And I think for us as humans, because we have we are particularly with video and pictures, because it's something that we find very we can relate to. It does give us a great sort of visual appreciation of the nasal passages and the urinary tract. Has anybody done any sort of treatment of because I don't know the disease prevalences of where you might be, but has anybody cut ectopic ureters like that before? Or gone up into the frontal sinus at all with endoscopy, or done trephination?
They are all clear for your presentation, and I think that's very useful for them.
Yeah.
Any questions can be asked, because I think it is a very good chance here to talk with Dr. Richard. It's a very, very good chance. Let me check if somebody is raising their hand.
Oh, what other management do you need to avoid bacterial introduction when doing trephination? Yeah, that's a good question. Look, it's basically just aseptic technique. Now, I don't do it in theatre. I do it in a procedure room. I don't really, I'll be honest, I don't drape because I want to see what I'm doing. I'm careful of what I touch. I use sterile gloves. I do a surgical prep over the sinuses. So do a surgical prep. And then I make an incision with a number 11 or a number 15 blade just to expose the bone, and then make a hole through the bone. So as long as you're using instruments that have been sterilized or been through the autoclave, because you can autoclave your scope as well. So your scope can have been sterilized. So if you use sterile material or sterilized instrumentation, and you're careful that you don't sort of touch the table or scratch your nose and then put your finger in the wound, it's a small hole that you're making. And as long as you are clean and just practice, the aseptic technique, you should be fine. Look, I might be jinxing myself. I've never had a problem with these before with infection. It tends to be quite forgiving. I'm not sure I understood the second one, management that we need to do. Oh yeah, that's a great question. So it depends on the width of the scope that you need to put in. So if you don't know what the width of the scope is, then just measure it with a ruler or with a caliper, the width of the scope with the sheath on, because you typically need to insert the sheath as well so that you can put your forceps down through the working channel and that you can flush. So my setup is 4.5 millimeters. So I'll use a 4.8 or a 5 millimeter IM pin or Sternman pin, or I've used a drill bit before, a bone drill, obviously. So if you have orthopedic equipment in your practice, you can use a drill, but the most practical is just to use a bone pin. So a pin that you would put into a bone, and it needs to be about 0.5 millimeter wider than the scope that you're trying to introduce. If you don't have a big enough pin, and oddly enough, that was actually a challenge for me today, what you can do is you can take a little rongier, a little bone nibbling device, and you can just nibble out the hole and make it a little bit wider. But the easiest way to do it is just to use a pin that's slightly wider than the width of your scope.
Okay, I think the answer is very clear for our audience online. And I checked before because I find our meeting is just only 2 hours. So I think if there's no more questions, so maybe we can over this Q&A sections. And if you have any other questions after this meeting, you can feel free to contact Dr. Richard and also contact us. It's also okay. Okay, so thank you so much. Thank you so much today, Dr. Richard. It's for your insightful and
it's my pleasure. And thank you everyone for joining, and enjoy your, like I say, I think I would just encourage everyone to get more adventurous with endoscopy. It's a great tool, and it's minimally invasive, and it really is something that adds value to our cases for our clients and our patients.
Yes, we gain valuable perspective on how to choose the rigid or flexible or rhinoscopies and cystoscopies in the clinical practice, and also the specific procedures according to some different scenarios. I have learned a lot from the class today. And
yes,
thank
you very much.
Yes, and thank you to everyone who joined us today. And your participations make these sessions truly worthwhile, I think. If you have any additional questions, so feel free to contact Dr. Richard or contact us. It's also okay. thank you again for joining us today, and wish all of you have a great day, and we hope to see you at our upcoming webinar.
Perfect. Thank you. Thank you, everyone.
See you. Thank you. Thank you, everyone. Thanks for your time.